Thank you, Professor. Ladies and gentlemen, it's a great honor to be here and among these distinguished speakers and the chair, and many thanks to Dr. Karamassis, Professor Deftereos, and Professor Philippatos for letting me doing so. And let's see. Let's start from acute coronary syndromes. Thrombus detection facilitates identification of an ACS culprit lesion, and OCT is the current gold standard for thrombus detection. And this implies the exclusion of an atherosclerotic etiology and should lead us to decisions about antithrombotic, antiplatelet, or anti-atherosclerotic therapies. Atherosclerotic versus non-atherosclerotic ACS. And when a culprit lesion attributed to an ACS presentation is not evident by angiography, imaging is imperative in order to guide appropriate management and further examinations. So, the other part is that we have to characterize lesion morphology and to identify plaque rupture and think up fibrotheroma versus plaque erosion, probable versus definite, and calcific nodule, eruptive versus non-eruptive, and also the non-atherosclerotic, as we said before, ACS presentation, MINOCA, and spontaneous coronary artery dissection. And as Professor Pareek showed you in the previous talk, intravascular imaging, and preferably OCT, is a class 2B in patients with ambiguous culprit lesion in order to characterize erosion, nodule, rupture, scad, or no lesion for these patients. Furthermore, with OCT, we may characterize plaque, and this has therapeutic apart from diagnostic implications. And disrupted fibrous cap with a lipid underlying plaque leads us to the classical pathophysiology of plaque rupture. But otherwise, calcium in the underlying plaque might signify a calcified nodule. On the other hand, an intact fibrous cap would lead us to, if there is thrombus, to the diagnosis, a definite diagnosis of plaque erosion, if it's the underlying plaque intact. If there is thrombus with no visualized underlying plaque or no superficial calcium, we might say that it's a probable plaque erosion, or there is no thrombus. Here are some examples. Here is a definite plaque erosion. We have thrombus with an intact plaque. Here we don't know behind the thrombus, or the red thrombus, and then attenuation, what happens. So it's a probable erosion. And here is a definite plaque eruption, the classical paradigm. And also for calcium, we have eruptive calcified nodules, superficial calcific seat, and calcified protrusion. And why we are saying that? Because we have data, strong data. Here is erosion 3 study results that you can see that when we had patients with STEMI, with angiographic stenosis below 70 and TIMI grade 3 presentation or after undergrade blood flow restoration, you see with OCT we had less staining. Patients were managed with no staining, and we have many erosions, 26% were erosions. The majority of them was done conservatively. We have some calcified nodules, conservative, and we have the classic rupture with the majority the classical way. There are pathophysiological differences also. In erosion, we have complex immunological mechanisms that have to do with the generation of white thrombus, no lipid core. We have neutrophils with those nets, neutrophil extracellular traps, and a complex pathophysiology with all the immunological or coagulation cascade mechanisms. And we have risk stratification for those patients. If we have patients below the age of 68, anterior ischemia, no diabetes, no CKD, and some biomarkers, and we have a confirmative non-invasive coronary imaging, we have a more likely diagnosis of plaque erosion. And then we might leave them without stenting. We are safe. And this is a very strong therapy. This information by imaging gives us a strong therapeutic paradigm. The other part is IVUS. IVUS could lead to a tragedy if it's not, if the information for it is not undertaken beforehand. So, imaging is the way to go. There are differences because IVUS cannot penetrate calcium, and OCT has the lower penetration force apart from calcium. So there are strong points and weak points for every method, but the weakest of them is classical angio. Angio cannot give us the information for calcium we need today for the means we have to modify calcium, and we have to know eccentricity, thickness of calcium, the depth, the length of the disease. And look here, it's a very recent consensus statement from SKY on the management of calcified coronary lesions. You see here two similar images in hinge points of the right coronary artery, and one is eruptive calcified nodule, the other is non-eruptive calcified nodules. They look the same, but they are different and they have different prognostic implications. Eruptive calcified nodule has far worse prognostic impact. Here's a case of ours. You see here the haziness in proximal circumflex, and we have to image that in order to know what's happening. And we find it was a non-disrupted endothelium and probably fibrocalcific disease, and we left it alone. Here's a paper from by Grigoris and the team of Attico for the use of intracoronary imaging in patients with ST elevation myocardial infarction. We don't have many data indeed, but in patients with MINOCA and stent thrombosis, imaging is imperative in many of them. You can see here it's a patient 1 month post-primary PCI. Grigoris knows the case, has seen that before, and there are some bullets shaped inside the stent, filling defects here and here, and we thought it was thrombus. It was thrombus, but we had to find out the mechanism, the red thrombus, and we have to find out the mechanism. There was no malapposition. There are areas of underexpansion, and we went there and fixed that with good results. Imaging gives us the diagnosis after stent thrombosis, and there are many scenarios. Neoatherosclerosis, late acquired malapposition in some cases, especially bioresorbable scaffolds, and underexpansion, evagination in older generation stent, stent crash, edge dissection, neointimal hyperplasia. And in the time period, the distribution of this diagnosis is different. Spontaneous coronary artery dissection. We should refrain from imaging except for type 3 dissection. And as you can see here, we had a probable type 2 dissection. It was many years ago, and we went to put a wire and go for imaging. And what we managed is to transform a type 2 dissection to a type 1 dissection. It's over 10 or 12 years ago. And then the final result was good, but the patient had some stents to fix that. And we don't do that today. It's something we should not do. Definitely we should not do if we have a definite diagnosis of type 2 dissection. We keep that for types 3 and for imaging. And the implications, the prognostic implication, it's totally different to have an atherosclerotic MINOCA for those patients, IDEST, plaque erosion, plaque rupture, or calcified nodules, we said before, than non-atherosclerotic MINOCA, SCAD, spasm, or unclassified cause. It's 5 times the risk for MACE for patients that have atherosclerotic MINOCA, apart from the decision that they have to take DAPT or anti-atherosclerotic drugs. So if we have to solve all these things in an algorithm, it's very good. When we have obstructive or non-obstructive coronary artery disease, we should go for intracoronary imaging, whenever we have ambiguous angiographic results, especially in MINOCA when we see normal coronary arteries, and if we find erosion, we should think if we should refrain from stating. That's the rule for many MINOCA cases when we find erosions or we find SCAD or other diagnosis apart from coronary artery disease. So it's a very strong diagnostic and prognostic implications. Finally, the last reason to use imaging is when we have to characterize the severity of the disease. And we know, we heard before by Professor Escanet that we have to rely on functional indices, but it's not true for left main disease. In left main disease, the sensitivity and specificity of IVUS as compared to FFR in delineating severe disease for which we have to intervene is excellent. And that is the guidelines. And we all know that patients with minimum lumen area above 6 millimeters square should be left in their peace. And there is a gray zone for 45 to 6. And then we have to revascularize definitely if we have lower areas. And this, of course, has prognostic implications, strong prognostic implications for those studies. It's my last slide. And I have to show you a study, a single-center trial, where OCT was compared to FFR by Burzota in order to take diagnostic, to take therapeutic decisions about the severity of some lesions. The use of OCT led to more PCIs, more contrast medium use, but lower MACE or significant angina as compared to FFR that led to more medical therapy, lower degree of kidney injury, and of course, by not standing, lower costs. It's a hypothesis generating. So, apart from PCI guidance, as you saw before, as my colleague showed you before, we have all this spectrum for pre-intervention strategies, especially when we have ambiguities, and we have good tools in our hands. Thank you for your attention.
Thank you, Dr. Pulημένos. We'll have the discussion at the end. So it's my great pleasure to present the next speaker, who is Dr. Keeble. Dr. Keeble is consultant cardiologist